Mm-mm. Mm-mm.
Go hard or go home. 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 Touchdown like the end zone. When the circle turn to my home, can't get me out of my zone. Go hard or go home. Go hard or go home. Yeah, these are championship rings on my hands now. In my head I'm top 10, yeah, that's hands down. You a squad, now you're looking man down. Funny how foes turn to friends now. Drive a race car like a Atari now. Call filling up, I need product again. Treat the business like a playground, might slide on you. Don't me wrong, might slide on you.
Oh, I thought up the Ellis name, huh? I thought up the Ellis name, huh? Can a dummy. Can a dummy, you was here for 15 minutes before schedule. Thank you. Look, Ellis, let me tell you exactly what I was thinking about with Ellis' name, right? I'm what, 13, 12, 12. I think I was 12. Yeah, I was 12. I was 12. And Ellis, he was like, if you tell anybody I like you, I'm gonna beat you up. Huh? He said, if you tell anybody, if you open my mouth, I'm gonna beat you up, huh? And I was like, for real, huh? You my girlfriend, you better not tell nobody. Huh? I swear, I ain't making it up. I think he got one arm now. I think he got one arm now. He been through some stuff. Streets. Streets, huh? I'm talking about street. Ellis's, huh? South Miami representing, huh? Oh, I could go on and on for days. I was a whore in my spirit. I had so many boyfriends before I even popped a cherry. Huh? Oh, this stream will be rated PG, uh, algorithmic error, year one, day, whatever day you want to make it today. Huh? It's your birthday. It's your birthday. I could go on and on. Oh Lord. Every time somebody put a name in the chat, I'm gonna come up with a story about a name connected to that name, unless it's a name I never heard of. Huh? I'd be like, what? Let me look that up, huh? Do y'all realize when you say, "Hey, computer," and the computer give you the answer from somebody that's just like you, huh? You ain't getting the answer from the computer. You getting the answer from somebody that's just like you. Somebody that said, "Hey, computer," and then they decided to put their own definition in there. I haven't heard the computer yet give a definition that she made up on her own, huh? Not yet. She said, an Amazon customer told me to tell you, huh? Huh? How do you know I'm not the Amazon, customer that you is clicking and putting the answer that Siri is giving you to put on your board? Did you know that? No, yes, maybe so. Hey, computer. Research and development, huh? Huh? Listen. I'm feeling mighty. I'm feeling good. I was very emotional. I was very emotional with the PCAST that I watched today, y'all, because they got me on a string. Like part of it sound like they about to be so transparent and allow us, like people like me, to be transparent. Like they really finna do some rectification, huh? Like they gonna force the doctors to tell the truth. Like they putting in this paperwork for it. You say you have the chance and the opportunity right now to be so transparent that people will have to make their own physical, like no more blindfolded going into this research and development. People have a real free choice to burn, huh, or survive bionic bind them. Look, I have a question. This question is about the sun. This question is about the sun. Somebody else may have asked this question before. You know, it ain't nothing new under the sun. Anything come out of my mouth was already here before I got here. So I'm about to ask this question. Can somebody answer it for me? If the sun's so hot right now, it's just burning stuff out of the world. Got the seawater at 101 degrees in the Keys, and it ain't doing nothing but getting hotter. They say that's the hottest anywhere in the world, and the hottest it's ever been in their recording. It's boiling, getting ready to boil out there, Key West. You know, going to the beach used to be a place you go to cool off. Remember? It's hot. We're going to the beach. Yay! Hell, now they say it's getting like a sauna out there. Now, here's the question about the sun. If the sun is so hot, yeah, it's doing that. How come the satellites ain't dropping out of the sky? They supposed to be blowing up and exploding right about now. Wait a minute. The closer you get to outer space, the closer you get to the sun, the colder it gets. Right? No? Wrong. Okay. Not bad. Where my honey at? My first digital. Digital. Talking about he want to be rogue. I can't take this. My wife told me if I don't leave you alone, because it seems serious, huh? And I knew her before I knew you, so I got to be rogue, huh? Hmm? I'm trying to be a true Muslim. I'm trying to be a true gullah gullah. I want my heart to be right too. I can't answer to you. I gotta answer to God. I love it. Huh? That's right, Kenna dummy. Huh? You're hot and you're cold. You're yes and you're no. In and you're out. There she coming with the pink color. You're up and you're down. Ooh, I'm eating my lemon. I'm eating my lemon. I'm detoxing. I'm detoxing. Okay, focal point. My bad. Thank you, Tanner Dummy. Thank you, JC. Even if you not James Cameron, you know that you related to James Cameron. You know it's in your blood. You know it. You know it when you look in the mirror. You be like, "Yep." Somewhere down the line, along the way, I'm a part of one of his clone DNAs. We is cousins from Mama, Auntie, Maureen, Elizabeth Finnegan, Can, Zelensky, Popowitz, everything. The plant of the earth, the soil, right? Can I dummy? No, my bad. Let me not do that because that make you run away. You gonna run away from me like everybody else can, dummy? Huh? Can I dummy? You been with me the longest, right? You ain't never left. Ain't that something? You ain't never left me alone. Oh, can a dummy love me? Thank you, can a dummy, for all that you've done to support me. Hmm. You don't agree with a lot of the stuff that I say, you still be here. You been right here with me, planting your love, just showing Canada me, and I don't even know. Well, I know what you look like. Well, the time you showed the video, you blowing your clarinet over there on Huey P. You show your face every now and then, or sometimes you just show a little statue. I want to see that statue. You should go live, Canada. I mean, Canada, go live, man. Huh? I got it. I got the lemon and the salt. Huh? I'm dipping it in the salt. Mm, mm. Then I got some mango skins and orange peel on the stove, soaking. I get that from my mama. Hmm. Okay, focal point. The focal point. Here we go. God is the focal point. GD. God. Ready, SETI, discussion and consideration of the report on a transformational effort on patient safety. Now, when you listen to this, they are going to be talking about things like sepsis, people getting infections in the hospital from cross contamination and um, uncleanliness in the hospital, if I could just put it in layman terms. That's what it sounds like they're talking about. But you have to remember this is about nanotechnology, artificial intelligence, and all of the research. They have to be transparent about beings that they've researched on to be able to let the world know that this is how transparent they're being. And even if some of the considerations and oversights seem negative, that they're letting you know that this next transition that they're telling you about, they're being transparent enough that you will have the choice. They putting it all in public PCAST. They put the P there for you, and the P is silent, y'all. So the cast, right? And I'm playing the cast for you because I believe in what they saying. Because I'm part of the research and development too. Huh? Okay. Then students that was interns and on internship through the research and development schools like Harvard Junior High was a direct research and development school through University of Miami. Things like that. And they telling you, they saying we took it, we had to do experiments. And now they want to give Vietnam vets their due service. Half of them, 80, maybe 90% of them Vietnam vets done transitioned. Now they want to listen. Focal point. Okay. Let me play this video and calm down. Okay. I should have stayed focused on you, Canada dummy. Mhm. I done got angry a little bit. I gotta remember, God is in control, huh? And He believes that His children will not be forsaken, huh? Because there's a discussion and a consideration of report, transformational effort on patient safety. Abigail, be quiet. Be quiet, Abigail. Can y'all hear it? Oh Lord, see what I done did now. Did the mic go out? Is it a silent stream? Come on, man. What's going on? I don't hear anything. Do you hear anything over on y'all end? Oh, London McLovin. I done messed up. Oh, wait, okay.
I
I
get to
hear
it first, I
something
got you
now.
mad. I guess that when I get to it
They
last.
not letting me share the
Get it that I'm never
video.
going
Wait
back.
a
Get it that I'm never going back. I get to it first, I got you mad. I guess that when I get to it last. Get it that I'm
Come on, man. They playing. London McLovin. How you? I'm glad to see you over here, Idris. Yeah, huh? Mm-hmm. Patient safety. Wait a minute. Focal point. Focal point. Where is my first digital? Huh? And for those of you calling my phone and leaving messages, I would appreciate if you would show yourself in my chat. No? Yes? Maybe? Kinda? No? Okay, then. And then I'm done. Okay, that's it. I'm not playing with nobody. If If I'm not playing with the government, what make you think I'm finna play with you? Now, come on and release my screen on whitehouse.gov. Is it muted? Let me share the screen so y'all can see up. Oh, I don't have share screen on my. I did. Oh, I wasn't sharing the screen. I didn't have the share screen layout. I didn't have the share screen in the layout, yo. Oh, slow. Oh, slow. 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 Wait a minute here. Wait. Share screen. What was I supposed to be sharing? This video right here. Dang, I ain't never gonna get to it. I'm making the research developers the workers. What does she call them? The workers group. Let me Google them while I'm at it. The workers group. Which phone I want to use? Hold up. The workers group. Mm-mm-mm. All right, now I'm gonna start a video while I'm looking up the workers group. Focal point. Focal point. Here we go. Here we go. I am the focal point. Yeah. It's still not playing. I thought I did something magnificent. Huh? My granddaughter said, "Well, Grandma, what is magnificent, really?" What? I said, "Oh, wait. Okay, wait a minute. I'm not sharing the screen. The volume. What's wrong? My mic must have done died or something. Your panel is a circle jerk, bro. Who? No, none of that. Who you talking about? Canna dummy, you talking to London McLovin? Huh? Huh? I love his panels, huh? They are scary, huh? I love his panels. They are scary. They scare me for being there. Don't be afraid. Live not in fear. Huh? You got a live without fear sound just like Red Squid, huh? They sound like they could be twins. For real. You know how they got the light skin, white skin twins? I listened to him. I said, he sounds like Red Squid. What is that, a Baltimore thing? I'm doing it too. I'm just keeping my mind off of the bullcrap while I wait on God to open up the heavens. Yes. Ooh. My family said, you go ahead. We staying, huh? We feel your vibrations. Huh? We're staying, huh? I said, good riddance. I'm going to make sure that the books is straight. Can I do that? Can I try to do that? No. You coming with me? Oh, y'all coming with me. Y'all ain't settling for ballot bindings. Y'all just going and telling y'all the family members what's going on. And you surrender all to God, and God is in control of everything, and everybody is living happy day to day as they wait, huh? We not worried about a thing, huh? Because we know God is going to cleanse the earth and save the children. Do y'all see the victims rising? The victims are victorious. What? It's not supposed to be no separation. It's love, 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 everybody. So everybody, let's have Thanksgiving in the prisons. No, not the misdemeanors. Everybody, you every day volunteer and put your work in. Do like the Seventh Day Adventists, and the Christians. You go in and do voluntary, no pay for years. You go in and you be a volunteer to speak to the most defecated minds that are alive, and bring them back up to be significant citizens that will abide by what artificial intelligence is about to do, that God said is about to take place. It was written, right? Yeah. No, I could do this because I'm part of research and development. Ask that lady that I'm about to do the focal point on. Focal point on PCATs, and the P is silent. Hey, where's my first digital display? No, you ain't over here. You rogue, huh? I can't wait to see you and your wife get remarried. I'd love to be here for that. Can y'all make that happen before God gets here? No, no, dang. Re-wedding. Huh? I know people that are great wedding. I'm just for real, boy. I'd love to see that. That'd be beautiful, huh? Y'all want to see that happen before God comes? Huh? No, I do. I do. Okay. No. Oh, okay. Anyways, huh? That's me. I be thinking about other people. Don't give a damn. They be like, "What the hell wrong with her? She must be a lab baby. Something ain't right." Tick tock, tick tock. Let me get to the focal point. We will begin shortly. Mm, mm. Hold up, hold up. Let me wipe my hands. Mm, mm. Them aspirin kicking in. Yes, I took aspirin. I had to. My blood pressure is getting too high. I was just laughing and laughing at everything. I had to get my blood pressure down quick. Huh? But I can't get it down too low while I'm detoxing, right? Okay. So then I got this right here on the side. I got I got hold up. Be right back. Wait a minute. Wait. Happy Sabbath, huh? Happy Sabbath to everyone. God is in control, huh? You enjoying that sunlight, huh? God's children won't get burnt, huh? No way. God's children ain't gonna get burnt. That's the way the story is written, y'all. Let's believe in the Bible for real. Just this one time, y'all. Just this one time, y'all. Let's help them finish our revelation with the thought. If we all come together as one, no, you already know you're gonna be all right. The streets is gonna be street to go. What? You ain't gotta worry about putting goals in your mouth, huh? If we go ahead and play out, why that's what happens. We stop playing. We get on the side of the mountain to say, I'm coming up on the rough side of the mountain, never getting to the top. Huh? Where's the song about getting to the top? Let's get to the top, y'all, huh? Everybody, let's finish the story, right? Remember, John couldn't finish the story, so we supposed to finish the story, right? Let's finish the story. Oh my goodness. Okay, play. It's playing and it ain't making no sound. The White House tripping, y'all. They don't want me to play the video. Why? Why? Look how the views going up while I'm on here. The views are still going up. Stream live 5 hours and it's still going up, huh? But they won't let me make a sound over here. Oh man, goodness. Let me try this again. There, that's on. Here. Wait a minute. Am I still hooked up? Can y'all hear me? Am I talking? It's all good. Cause I guess y'all hear me. That's messed up. I guess this won't be the focal point. I'll talk about it. I could let the video play and kind of ad lib. I know they don't want me to do that. Oh, that's what they finna let me do. All right, that's what I'm finna do. I'm finna ad lib, huh? Now, I bet you the stream gonna start pumping in a minute because I know StreamYard is not about to block me, huh? I already know. Yeah, that's right, huh? I'm gonna ad lib, huh? Here we go. Play with it, huh? But hurry up. Let's get it going, huh? Oh, maybe because it ain't nothing on the screen. That's why I can't hear nothing. Wait a minute. Wait a minute. Okay. Look at What are the effects? We need see she fixed her hair. They watched my live yesterday, y'all. She looked like she cares today. She looked like she cares today. Here, see, she looked like she washed her hair and all. She said, whatever it is about my hair, and you let me go up there. And I think she's telling the truth and being transparent. And this is what we're looking for. Fix my hair. Huh? Thank you for listening. This is transparency, y'all. She changed her hair. She actually did something different. Hold up.
Of our July meeting.
Don't it look clean? Now let's compare. This is research and development from yesterday. Let's see if I could go to it. I'll go to yesterday after I finish because I don't want to lose it. Oh, they let it play. Oh, you can hear her voice now. Here we go.
This is a virtual meeting, and the next meeting in September will be, the current plan is to be in person, but it could change on the basis of scheduling in DC.
Oh, look at this. This ancient right here, y'all. Look at that. There it is again. Isn't these the same symbols that was on the chairs at the State of the Union address? See this behind her? Y'all remember? The royal blue chairs with the gold pattern. This right here, this pattern that's behind her. At the State of the Union address when they did the play with Ireland, and the Panamanian Queen, Princess. No? Well, it looked like the symbols to me. That looked like the symbol right there. Now here we go.
And we'll see how that goes. I'd like to inform everybody that this meeting is public and it's being.
What stone is that on her neck? And it's in an O. Is this a part of the OA? Oh. Ooh, y'all ready? Let's see who could the longest. You ain't gonna on with me? You could do that. Y'all ready? Ready. Steady. Ready. I'm doing all this in my mic muted. I'll be mad. Nope, it's not muted. Ready? My mind is God's mind. I'm always reflecting divine wisdom and divine intelligence. My brain symbolizes the capacity to think wisely and spiritually. God's ideas unfold within my mind in perfect sequence. I'm always poised, balanced, serene, and calm, knowing that God will find the perfect solution to all my needs. Amen. That you owe to Harvard Research and Development. Me using that quote right there, that's who you owe it to. If it benefits you, thank Harvard Research. Ready? Let's see who could own it the longest. Ready? Ready? Wait. Ready? Nah, dang, man. I didn't count how many seconds. Focal point.
Being recorded. Recordings will be available for anyone who misses the live stream. And to get right to it here, I'd like to pass the proceedings over to co-chair and president science advisor, Arthi Prabhakar, who will moderate today's session to discuss PCAST letter to the president and a report on patient safety. Arthi?
Okay, it's great to be back with everyone. Thank you so much, Maria.
I don't know
We're going to
that.
kick off by discussing a very important topic that has been the subject of a lot of work from folks on PCAST. This is a report to the president.
Miss Arthi, I'm asking you live, and I know you're going to get a whiff of this, huh? You can tell by the shape, huh? If you turn to the side, that you have been on the walls of Egypt, huh? Now, I ask you sincerely, huh? If you could be transparent enough to let the people know that I am not exaggerating, huh? That you have sat and questioned me before, huh? And that you can let me know the questions. This would help in the transparency of it all, huh? You know how many lives will be saved and transitioned based on the transparency that you give out right now. You have people here who question, will the doctors ever tell the truth, huh? You're the doctor, huh? You're a good doctor, huh? And the time is now, huh? And with this transparency, huh? I swear you could put me in a room and let me go ahead and finish out my time, huh? In a little box in a corner in a room, huh? Where I could just sit with my grandchildren, huh? And go live. Huh? You're not gonna do that. That ain't a fair trade. Huh? No. That's not no, that ain't a fair trade. That ain't a fair trade. Ain't no trading. Ain't no trading. It's no trading. It's no trading. You got to be transparent no matter what I say. That's the flesh talking. God is in control of that. He the one with the answers to all that the mind games that y'all have played against me and mine. It is time for you to be transparent, and I'm saying it directly online live, y'all. She has it in her file somewhere. Her stuff didn't get messed up in the hurricane. Her files and paperwork ain't get burnt up or lost like between Biden and what you call it, them. Huh? Oh yeah, yeah. Head honcho, huh? Head honcho in charge. We are waiting on the transfer. They said they throw in here that they talking about sepsis and all that in the hospital. I said that earlier. This is just a glitch in the matrix. But they're talking about patients like me. And they let you know that, we need the transparency because then you're gonna have people talking about acting like they whistleblowers. They ain't whistleblowers. If we go ahead and address this and nip this in the bud, we can do whatever the hell we want to then, huh? That's how they talking. I'm gonna let you listen to it. But we putting it out there in public. We can't let her win and get the authority just like that. Ooh, it's something different we could do. She feeling the sympathy in her heart. She trying. She trying. She's like, yeah, we messed up, but ain't nothing we could do. We can't even come and reprimand her on YouTube and StreamYard, y'all. So we have to address this out loud, huh? She want to offer me jobs and everything. Look at her. She tried. She tried. She said, we know we messed up, y'all don't believe that's possible. Y'all don't believe that's what this stream about. Let's get on the focal point. My bad. Here we go. Shut up.
Called a transformational effort on patient safety, a critically important problem that we've been wrestling with and have not yet solved fully, and that's the focus of this work here at PCAST. Eric Horowitz and Joe Chiani have been doing a lot of work leading this effort, and I'm going to start by turning it over to them to tell us where they are.
Well, thank you and good morning. I'll be presenting the findings and recommendations of the PCAST Working Group on Patient Safety. The group has spent considerable time exploring strategies to tackle an urgent issue, which is the high incidence of adverse events that patients nationwide encounter during their medical treatments.
Okay.
Before diving in, I'd like to, next slide, please. Before diving in, I'd like to note that PCAST is an independent advisory committee that provides advice to the president on matters involving science and technology. We form working groups to address particular challenges.
Okay, my bad.
and opportunities, and do information gathering from a wide array of stakeholders. We draft reports like the one we've done for patient safety. For a report to be released, it must be approved by the full council in a public forum involving discussions and voting. Next slide. I served as co-lead of the patient safety working group along with my fellow PCAST colleague, Joe Chiani. We benefited from the insights and guidance of our fellow PCAST members, Lisa Cooper and Sue Desmond-Hellman, and from our external members who bring a wealth of expertise to the table. The cross-disciplinary team comprises long-term patient safety advocates and clinicians specialized in outcomes research, including Don Berwick, Chris.
Boy, they keep showing these people look like Nikki C, y'all. The one that was earlier in the, that's her family. There you go. Huh? The Coopers are the coppers? I don't know. I don't know. Let me check. Let me check. What? She said John Hopkins. She worked with, what's his name? Ben Carson? Maybe. No. Different department. Who knows? I don't know. Hellman's. Hellman's real mayonnaise. Hellman's. Sue from Hellman's. Not Hellman's. I done sat in their office with their head people. I done gave them a hard time. Sue from Hellman's. Stop it. Let me look. Let me let me see if this Sue from Hellman's mayonnaise. On everything, copper. Everything. Hold up. Wait a minute. Can't be. Please let that be another Hellman's and not Hellman's mayonnaise. I'd have had them call me into the office to question me. Hellman's, that can't be, not that Hellman's. No.
Hello, Moto.
Yeah, because when I used to go into these places off my truck, I could come in with an attitude, especially if I had to boo-boo before I go in there. Huh? Hellman's. Hold up. My phone just came on. My bad. Sue Desmond. I'm gonna make me a mayonnaise sandwich. If this Sue Desmond is Hellman's mayonnaise. Sue Desmond. Desmond. Peacekeeping and Protection. United Nations just went live or something. They just dropped a video. Hellman. It don't say Hellman's with an S. And it has two L's, right? I don't know. Chief Executive. She's an oncologist. Hellman. Wait a minute. Chief Officer. Productive. Herceptin. Cancer drugs. Oh my goodness, she looks so familiar. Oh yes. Ooh, California, Berkeley. Ooh, personal life. Hellman, 1987. Nicholas Hellman. Is it Nicholas Hellman? The Hellman's mayonnaise. Oh my goodness, is this what you was talking about? Hold up, swole up, eggs in the mayonnaise. Wait a minute. Oh, hold a minute. Oh, wait. CEO, I'm so slow of, yes, I'm waiting on redemption. The Tor just dropped the video, y'all. He said, waiting on redemption. CEO of Hellman's. How do you spell Hellman's real mayonnaise? Oh, it's with the 2 L's. Oh my goodness. Ryan hiking. Ryan hiking. Who? Howie help. Hellman appoints Howie. Ain't that's the phone company? Hellman, what? Hellman's revenue. Wait a minute. Worldwide logistic. Carl Henrik. I don't see Hellman's mayonnaise name on here. Okay. Okay. Why did Hiken name it Hellman? Hellman Worldwide Logistics. Oh, Carl Hellman. Oh, it's the same dude. Wait a minute. Oh my goodness. Wait a minute. No, 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 no. It can't be Carl. Carl Mayonnaise. Oh, he old. He looked like 1800s. According to the mustache build of their Red Squid X. You want to know about mustaches and what each mustache means and how it means they took their mustache. Hellman, he was a war veteran too. Oh, he did some funky stuff to the Hellmans. Look at his mustache. Oh, my grandma, that was one thing she couldn't stand to see on a man. I just said, and people like to kiss men with mustache. They say all that hair on their face. Oh, no, 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 no. Shave it off. Magic shave. We say, Grammy, why Grandpa can't use something else? Because magic shave. Ew. I don't believe in kissing anyway. God ain't say nothing about slopping all that spit in each other's mouth. What is that? That's a sin. They eat and blow their nose, and then you want somebody to kiss it nasty. You know, when they start putting kissing on TV, my grandma thought TV now had really went to hell. When she started seeing they just kissing, y'all, I know. She said she don't watch a bunch of stuff no more, huh? She said, no, not how they kissed back in the older movies. They kiss and pop, lips holding together, and they pretending and holding. She said, all of a sudden, everybody opening their mouth and making all that noise. I used to sit there, I'd be drawing or doing something, laughing in my head. When they start putting kissing on TV, my grandma said, TV had done went to hell. Huh? I don't have to talk no more. Huh? I'm going to go relax my mind. Maybe go do some artwork for my grandson to hang on their walls or something. Mayo Clinic, they exist, huh? Who wonder? Yale, Harvard, who knows? Greater light. I can't get to the focal point today. Yes, I can. I could be quiet. I'm gonna take the thing off my head and stay in the chat or something. I got to play this because it ain't about me. It's about God. It ain't about my grandma and beards and mustaches. It's about God.
Chris Hart, Harlan Krumholz, Julie Morath, Peter Pronovost, and Sue Sheridan. And we also benefited early on by the insights and guidance from Francis Collins and Rachel Florence. In total, the expert perspectives have shaped the findings and recommendations we'll be discussing today. Next slide. Clinicians across America are deeply dedicated professionals who strive to provide the best care for their patients. But despite their unwavering commitment, preventable adverse outcomes occur at alarmingly high rates among patients. These include, but are not limited to, misdiagnosis and delayed diagnosis, infections, bleeds, medication reactions, organ injuries, and falls. The prevalence of avoidable adverse outcomes represents a significant public health challenge across the nation. Now, in a groundbreaking National Academies report, to Err is Human, published in 1999, significant attention was drawn to the issue of patient safety. The report estimated that avoidable errors in healthcare delivery were causing a staggering 44,000 to 98,000 deaths annually. And in the years following that report, numerous initiatives have been implemented by hospitals, healthcare organizations, and federal agencies, including the Centers for Medicare and Medicaid Services, CMS, the Agency for Healthcare Research and Quality, AHRQ, and the CDC. Now, CMS established two patient safety incentive programs. The first, launched in 2005, it stipulated that Medicare would not cover the increased costs associated with certain preventable hospital-acquired conditions, providing an incentive for hospitals to implement evidence-based prevention guidelines. The second program penalizes hospitals that rank in the bottom quartile on safety measures computed from administrative claims. Now, under this program, CMS reduces the hospital's annual Medicare inpatient fee-for-service payments by 1%. Despite these well-intentioned efforts, numerous studies have suggested that these programs have fallen short of their intended objectives. Next slide. So while strides have been made, and some strides have been made in addressing specific adverse outcomes, the stubborn persistence of costly patient safety challenges is an issue we cannot ignore. Now, I'll just mention 4 recent studies that provide a compelling snapshot of where we currently stand as a nation. Last year, the Office of the Inspector General, OIG, released an in-depth analysis of the state of patient safety in our country using data from 2018. The report revealed that almost 1 in 4 hospitalized Medicare patients experienced an adverse outcome, and nearly half of these have been prevented with improved care. Now, besides the tragic human toll in terms of morbidity and mortality, the financial cost to the nation was estimated in the hundreds of millions of dollars. The OIG report specifically criticized CMS's 2 payment incentive programs as not applying to the vast majority of harm events that patients experience. Now, further echoing these sentiments, a study published in the New England Journal last January confirmed the OIG finding that nearly 1 in 4 patients experience adverse outcomes. The study, conducted by a team at Harvard Medical School, used clinician-curated data from multiple hospitals, and they found that over 20% of hospital-acquired adverse events were preventable. Moreover, it reported that nearly 10% of these adverse events were severe or catastrophic. Next slide. The authors of the Harvard study provided a summary that aptly captures the fundamental aspects of our recommendations for progress. They emphasize that despite stunning advances in medical science, we still have important gaps in patient safety, and they note as a problem that U.S. hospitals rely solely on voluntary reporting of adverse events, which results in substantial undercounting. They also describe the considerable variability they saw among hospitals in adverse event rates, with some sites showing adverse outcomes in over 40% of patient visits. Lastly, they propose a strategic direction to improve patient safety measures, including the utilization of electronic health records to identify adverse events through computerized triggers and the leveraging of AI. Next slide. Now, recent research has revealed that the challenge posed by adverse medical events is even more extensive than what is typically revealed through conventional considerations of hospital-acquired conditions. Specifically, misdiagnosis and delayed diagnosis are significant and often overlooked. In December of last year, AHRQ unveiled a study that showed an alarming number of misdiagnoses occurring in U.S. emergency departments every year, leading to over 2.5 million adverse events annually. And this month, a study published by researchers at Johns Hopkins further underscored the seriousness of misdiagnosis, estimating that over 500,000 Americans suffer permanent disability or die each year due to misdiagnosis. Now, interestingly, we'll come back to this in a second on the recommendations, their research found that just 5 diseases account for 40% of these severe outcomes. The team expressed hope in making great progress by directing technical advances and refining practices to assist physicians in making more accurate diagnoses for these 5 disorders. So in response to the challenges, our PCAST working group, next slide please, has outlined several key areas of focus that can move us forward with improving patient safety. These include implementing reliable and efficient methods for measuring adverse events, standardizing strategies to identify and mitigate preventable adverse events, highlighting crucial organizational elements such as promoting a culture of safety, encouraging participation and coordinating efforts on safety and quality. And finally, actively pursuing avenues for integrating technical advancements into clinical practices. Next slide. Now let's dive into our recommendations. We propose that the president establish a White House-led transformational effort on patient safety. The initiative should foster a comprehensive collaboration of government agencies to address critical patient safety challenges across both public and private sectors. So the ambition is to achieve long-term tangible success over a decade and to significantly, measurably, and sustainably minimize avoidable injuries to patients and healthcare workers and reduce disparities in patient safety by 2030. We recommend charging the Secretary of the Department of Health and Human Services, HHS, with the responsibility to coordinate these efforts across agencies with accountability to the president for progress, and suggest quarterly reporting by the secretary to the president to ensure sustained focus on these issues. We further recommend the establishment of a patient safety coordinator role within the White House. Now, this role would engage non-government stakeholders, thus complementing cross-agency, cross-sector efforts, much like the coordinator for the Cancer Moonshot program. This coordinator would collaborate closely with the secretary and would remain the primary figure for patient safety to enhance systems. Sorry, the secretary would remain the primary figure for patient safety to enhance systems within HHS. Lastly, recommend that the president instruct the HHS secretary to establish a dedicated, independent, multi-party stakeholder healthcare safety committee. The National Patient Safety Team would study avoidable patient safety challenges and issue non-binding, learning-focused safety recommendations. The concept of the MPST is modeled after the Commercial Aviation Safety Team, CAST. It would include multidisciplinary clinical expertise, informatics and AI experts, data scientists, safety scientists, human factors experts, and importantly, insights from patients and their families. Next slide. Our second overarching recommendation centers around ensuring that patients receive evidence-based solutions for preventing harm. We propose the following sub-recommendations. Identify and address high-priority harms and promote patient safety through incentivizing the adoption of evidence-based solutions and require annual public reporting. Current programs, as multiple studies have shown, only tackle a small fraction, 2 to 5% of avoidable harms. Yet significant strides have been made in formulating evidence-based solutions over the last 2 decades. We advise the HHS Secretary to collaborate with the DoD and VA to generate a new, more comprehensive list of high-priority harms and their corresponding evidence-based practices. The HHS Secretary should direct CMS to develop, implement, and continually assess strategies to incentivize hospitals to use evidence-based patient safety solutions, particularly those aimed at high-priority harms. Now, in revising the incentive program around patient safety, we suggest CMS should only pay for the additional cost of certain hospital-acquired conditions if the related evidence-based practices are employed. And we note today, for the smaller number of practices, CMS does not pay for the additional cost of the named hospital-acquired conditions. We also recommend mandating annual public reporting of high-priority harms by healthcare organizations. We also further recommend creating a learning ecosystem to ensure the successful implementation of evidence-based practices and achievement of reduced harms. By a shared accountability, we mean that HHS and health systems should work together to realize safety goals, including collaborating on reviewing rates of top harms and effectiveness of mitigations. To increase board and executive accountability for safety and quality oversight, CMS should add metrics and perform surveys that relate to healthcare organizations' executive leadership and board accountability for patient safety, and to employ tools like ARC's survey on patient safety. CMS should promote the implementation of the Communication and Optimal Resolution Program called CANDOR, or Communication Resolution Program, to achieve resolutions in cases of patient harm. We further call for improvements in interoperability of healthcare data and guaranteeing access to data within the constraints of HIPAA that would enable better understanding and tracking of harms, and understanding the value of evidence-based solutions. And we seek efforts on safety for healthcare workers through supporting a culture of clinician safety in healthcare systems. We can't really have patient safety without healthcare or clinician safety. And we hope that HHS, VA, and DoD will work to identify and address clinician workplace injuries. As we document in the report, clinicians grapple with the risk of physical harm, such as exposure to infectious disease, musculoskeletal injuries, and exposure to violence, and psychological harms, including mental health challenges, exhaustion, sleep deprivation, and burnout. On culture, the National Patient Safety Team we mentioned earlier should encourage implementation of mechanisms that foster openness, feedback, psychological safety, reporting, and when necessary, whistleblowing protections. Next slide, please. Our third top-level recommendation is to partner with patients and reduce disparities in adverse outcomes. It's important to foster collaboration among multiple stakeholders, including healthcare organizations and patients, families, and communities most affected by unsafe care. Special attention must be given to studying and addressing long-standing disparities. For example, disparities in receiving timely, effective care for hypertensive disorders of pregnancy and postpartum complications, such as hemorrhages and pulmonary emboli, substantially contribute to disparities in maternal morbidity. These symptoms require careful, urgent, and non-biased assessment, which people experiencing marginalization are less likely to receive. To address disparities in patient safety, we recommend a whole-of-society approach. Federal agencies should seek meaningful and robust participation of diverse patients, family members, and patient and community organizations, including people who have experienced harm from unsafe care, patients from communities who experience marginalization, as well as those who have experienced higher rates of harm. We recommend that HHS, DoD, and the VA should establish competitive awards for capacity building for patients, family members, and community organizations to enable diverse input, two-way communication, and co-development of patient safety solutions. And to enhance data and transparency and to mitigate disparities, we recommend the President direct the HHS Secretary to require AHRQ to develop and validate new questions for the Hospital Consumer Assessment of Healthcare Providers and Systems Survey. This is a patient satisfaction survey. These should include assessments of racial, ethnic bias and patient safety, allowing CMS to gather data on patient perceptions of racial, ethnic bias through existing surveys. We propose AHRQ pursue and encourage efforts to collect, analyze, and disseminate information on racial and ethnic disparities in patient safety. Our fourth overarching recommendation is to accelerate research and deployment of safe care practices, technologies, and exemplar systems of safe care. Beyond today's knowledge, it's important to develop and deploy new technologies and processes for safe healthcare so that errors and injuries are minimized. Promising directions include harnessing new computing technologies that assist with medication selection and management, improving accuracy of diagnosis, shortening the time to diagnosis, doing new kinds of monitoring, as well as making predictions about treatment effectiveness based on individual characteristics. We recommend developing a national patient safety research agenda. HHS, CDC, NIH, and other relevant agencies should develop a 10-year R&D program to leverage computing and information technologies and health technologies to address healthcare safety challenges, especially for marginalized populations. We also see a great opportunity to harness revolutionary advances in information technologies. Multiple studies point out the promise of harnessing computing technology for patient safety, such as event capture from logs, non-invasive monitoring, data analytics, and AI for diagnosis and prediction. We propose an AI for patient safety program through relevant HHS agencies, collaborating with the FDA to share best practices, patient safety data sets, and information on technology integration within hospital workflows. And finally, we recommend pushing for fast-paced advances in our federal healthcare delivery system capacities and to showcase results in those systems as exemplars for safer healthcare. The DoD and VA are well-positioned to develop federal healthcare delivery systems as leading prototypes for safer healthcare. The Secretaries of Defense, HHS, and VA should demonstrate their commitment to patient safety by facilitating implementation of PCAST's recommendation to prioritize dramatic patient safety improvements and workforce safety improvements in their respective healthcare delivery systems, with measurements of systematic progress and results, regular reports to the president, and so on. The aim to be bold and clear within the next 5 years to make the military health system and the veterans healthcare system outstanding, instructive examples of safer care for both the nation and internationally. We believe that our 4 main recommendations form the foundation of a much-needed transformational initiative on patient safety. The primary recommendations, complemented by their respective sub-recommendations, possess the potential to amplify long-term endeavors by various agencies and organizations that have been dedicated to reducing adverse outcomes in healthcare settings. We see the recommendations as serving to fortify and build upon the work to date. Next slide. I'd like to express our gratitude to the leaders in patient safety at federal agencies who dedicated their time and expertise to providing us with insights about the challenges they face, ideas on directions forward, and with feedback on our ideas as we develop them. We were impressed by the passion we saw about the goals of reducing rates of adverse outcomes in healthcare. Next slide. Beyond healthcare agencies, we've learned a great deal from our sessions with numerous organizations, including experts at OSTP and the Domestic Policy Council, hospital systems, healthcare organizations, and leading scholars in outcomes research, AI in medicine, safety systems, and human factors. Here are just some of the teams we met with over the last year. Next slide. We received a great deal of feedback along the way, and I'll highlight 4 comments on our responses and incorporation of feedback. Although there were differences of opinion, some experts thought that conditions of participation, COP, is too hard or too strong of a hammer, and it would be better to provide positive incentives. In response to this comment, we shifted language, putting the ultimate decisions on the need or use of COP in the hands of leaders of the transformational effort. But we want to note that conditions of payment already requires hospitals to, quote, track medical errors and adverse patient events, analyze their causes, and implement preventive actions and mechanisms. We discussed current definitions of hospital-acquired conditions capture only a small fraction of adverse outcomes. Voluntary reporting is inaccurate and incentives are weak. So within the COP intention of the current COP, we're seeking change of definitions and approaches. So we recommend a review and revision of these distinctions of preventable hospital-acquired conditions, new incentive processes and programs, accountability and reporting, including transparency requirements. Another comment we got was, what about budgeting for these changes? We introduced language on budgeting, saying that the coordinator of the program and HHS director will engage with the Office of Management and Budget to work to identify resource needs and funding for these activities. Now, we note that with proposed incentives of our recommendations, Medicare pays increased expense of care for listed hospital-acquired conditions if evidence-based practices are in place, versus today, there being no pay for additional costs of these conditions. So in some ways, there's relief to hospitals that are doing the evidence-based efforts. Given the high monetary cost in the hundreds of millions of dollars, potentially moving into billions of dollars to the nation, we see these evidence-based practices and recommendations leading to overall large Medicare cost reductions. Of course, how those budgets work and how budgets come back to assist with these programs it will be a challenge. Next slide. Another comment was there's concerns about potential burden of these recommendations on small including safety net hospitals in poor financial circumstances. We introduced language that leads need to coordinate on special needs of specific types of hospitals, saying that in several places, HHS should provide additional support to hospitals that lack adequate resources, such as safety net hospitals and those serving disproportionately affected populations. Again, there's some benefit with removing the CMS penalty of not paying for the costs of hospital-acquired conditions if evidence-based practices are in place. And one of our reactions to this comment was, given data on disparities in the quality of care, it's critically important to bring proven evidence-based practices. Another comment we got was, what about budgeting for these changes? We introduced language on budgeting, saying that the coordinator of the program and HHS director will engage with the Office of Management and Budget to work to identify resource needs and funding for these activities. Now, we note that with proposed incentives of our recommendations, Medicare pays increased expense of care for listed hospital-acquired conditions if evidence-based practices are in place, versus today, there being no pay for additional costs of these conditions. So in some ways, there's relief to hospitals that are doing the evidence-based efforts. Given the high monetary cost in the hundreds of millions of dollars, potentially moving into billions of dollars to the nation, we see these evidence-based practices and recommendations leading to overall large Medicare cost reductions. Of course, how those budgets work and how budgets come back to assist with these programs, it will be a challenge. Next slide. Another comment was there's concerns about potential burden of these recommendations on small, including safety net hospitals in poor financial circumstances. We introduced language that need to coordinate on special needs of specific types of hospitals, saying that in several places, HHS should provide additional support to hospitals that lack adequate resources, such as safety net hospitals and those serving disproportionately affected populations. Again, there's some benefit with removing the CMS penalty of not paying for the costs of hospital-acquired conditions if evidence-based practices are in place. And one of our reactions to this comment was, given data on disparities in the quality of care, it's critically important to bring proven evidence-based practices to underserved areas. Finally, there was concerns that quarterly reporting, which we initially asked for, would be too difficult to implement and would lead the report to not being taken seriously. We moved the requests to annual reporting with a goal of shifting to quarterly reporting over 5 years. With that, I'll stop for discussion, questions, and feedback. And also maybe I'll ask Joe Kiani if he wants to add anything first, my co-chair.
Thank you so much, Eric. That was excellent. I know we worked on this for over 2 years with so many people. We appreciate co-chairs and the PCAS to vote to do this important work. Our compass has been patients and their families, and the many nurses and doctors that get very badly affected when medical errors do occur. So we're excited about this, and I'm happy with Eric to answer any questions you have.
Great, thank you both. Thanks, Eric, for going through that, and Joe, the work that you all have done along with the team, much appreciated. So let me start by turning to Bill Daly for the first question.
Well, first, let me thank you and congratulate you on a really great study addressing a critical problem and a great need for the nation. My question has to do with transparency. You mentioned transparency briefly in regards to recommendation 3 on reducing disparities, but it strikes me that transparency could play a much larger role in getting people to adopt the evidence-based practices and reduce medical errors. Our automobiles are much safer today, in part because the Insurance Institute tests cars and they publish safety ratings, and everybody is very eager to buy a car with a 5-star safety rating, so the manufacturers work very hard to make the cars safe and achieve those ratings. There seems to be a complete lack of transparency in the medical establishment. There's no place I can go and look and see, which hospital has a 5-star patient safety rating and has larger or smaller incidents of medical errors. It would strike me that if that information were widely available to the public, then hospitals themselves would be very highly motivated to try to get those safety ratings up and adopt these practices. Can you comment on the role of transparency in patient safety?
Absolutely, Bill. We actually, it's a big part of our recommendations. Today, a fraction of hospitals report their harm to CMS, and it's opaque to the public. So we are asking hospitals on their website to report their preventable harm, first on an annual basis and eventually on a quarterly basis. And you're right, we think that in itself will make every hospital want to be a 5-star hospital, let alone give warning to patients and families before they go to a hospital that has poor rating.
And yesterday we talked in our PCAST meeting about just this effort to make public the pollutants coming from different industries, and how that going public had a huge effect back on the boards of directors and up and down the chain of industries that were about their exhausts. And in the same way, we believe that transparency will be critical and transformative. There's been pushback on what that would take. We're hoping that electronic tools will ease the burden, definitions and standards for how reporting happens, and sharing among the agencies for how to do that well, best practices.
Do you see any downsides to that transparency?
No, we don't. We've studied it with experts. They think just like for public companies, where public companies quarterly report their numbers, regardless of what they make, and it helps investors decide what companies they want to invest in and not. We think this will have a similar effect, and really don't see any downside. In fact, I know there was some pushback about the difficulty of doing this. Many of us serve on boards of hospitals, and we know that hospitals already do this internally. They review every adverse event, and on a much more regular basis than even quarterly.
Yeah, and Francis, just a comment,
Yeah, and then I'd like to turn to Terry. So wrap up, Eric.
really briefly,
Next
we're throwing a stone into a very complicated socio-technical system, and almost any recommendation we make will certainly have to be monitored to understand its implications. But this is our best effort set of recommendations.
Okay, great. Terry, please dive in.
Yeah, this is a fantastic report. It's going to save lives, literally. So my question is following on Francis. Is there any risk that hospitals or healthcare practitioners might have perverse incentives to maybe reclassify high-risk harms as some other kind of harm that is less visible in these reportings? I mean, I doubt that they will deliberately try to do this, but once the incentives are there, there may be unexpected consequences. Have you thought about these issues?
One thing we call out in our report
Absolutely.
is, thanks, Terry. One thing we call out in our report is that the leads and coordinator and all involved have to stay on it. It can't just be, we have this one program in place with the simple list and we just let it go, but continue to monitor and react and adjust in a control theoretic way. So we understand various kinds of gaming that might occur, even inadvertently, or various pressures that might show up across the system. So I think, yes, we have to sort of watch out for these kinds of things.
Yeah, just one quick to add on that question, because I think it's so important for the last two questions that were asked. The culture and the tone from the top, the hospital CEO, it's impossible to overstate how important that is. So people will report, people will feel proud of reporting and working on getting better if that's the expectation.
I'm talking about my memory coming back good. Her too. This lady, she has sat in front of me with pen and ink, with paper and ink. I'm not exaggerating. I'm not making it up, even if it was briefly. I remember her. She's hilarious.
Not hide the ball, just push it to the side. So So culture and leadership matters.
She knows how to get you to feel comfortable, like in a room setting. If you come in nervous or you're nervous, some of them that's like straight to the point, you know. But her, I remember her. Maybe and not no long drawn out session. I didn't have a long like she might have been in with a panel of somebody or me in a room with her and other subjects or something like that. Okay. All right.
Tremendously on these things.
Yeah, and I think the one thing I'd like to add is just like, again, the example for public companies reporting their numbers, we all have to worry about if we don't, there could be a whistleblower that will expose us. So I think that same idea is everywhere. And so therefore we hope people will not be dishonest about it. And as Sue said, those who really are enlightened understand the sooner they report problems, the sooner they can come to a solution to avoid them in the future. So it's very seldom that these errors occur because of a human acting badly. It's really systems that need to be improved for errors to not occur.
Can we turn to Kathy?
Sorry, I just wanted to chime in
Please,
on
Lisa.
this particular issue as well. I think that there are some concerns around the impact of transparency on some organizations that might have more difficulty achieving, like doing this reporting, right? And so I do think that one of the real concerns that still exists is the use of disincentives for people who aren't able to do this reporting. And so I just want to say that I am one of the people that sort of is more on the side of using incentives rather than disincentives, because I do think that there's a potential for organizations such as safety net hospitals to be disadvantaged by, policies that use disincentives.
In my bag, because y'all know I'm not saying much with her look. And then that always, anytime I see that thin top lip and that thick bottom, my mind automatically, it's my mother, their family, their genes, the connection or whatever. For real, that thin, even lip shapes. You got people that can tell everything about you by your walk. You have people that can tell you how many generations you go back by the shape of your lips. Uh, Not getting down to see what's under the skin and all that is a whole nother ball game. But you have people that can look at the shape of your eyes and determine if you come from Aboriginal seawater monster people or if you come from on top of the mountain. And I'm just saying, I'm just saying, uh, I just let her go ahead and say what she's saying.
So I just wanted to make sure that was clear.
Yeah, and if I could
Lisa,
just address that.
I want to just chime in on this, and then I'm going to jump to Kathy. I'm going to take moderator's prerogative. I think there's a lot to be learned from safety in for-profit enterprises, factory floors, or transportation systems. And I think it's important to recognize that if a for-profit company goes out of business because it's been outcompeted by someone else that builds safer automobiles, that's actually different than our safety net hospitals that we rely on to serve so many parts of the country. And so I think it's been a very healthy and an important debate about which of those levers. I'm going to go to Kathy.
Thanks, Arthi. As I was reading this report, I was just struck by all of the data that you had brought together.
Oh my gosh. If you dye her hair black, y'all remember that Nurse Wretched? Nurse Wretched. Do anyone remember Netflix Nurse Wretched? And there was a character in there that played the role. She looks like her. She looks like if she dyes her hair, she's that Nurse Ratched character. Let me listen to what she has to say.
And also by the very thoughtful set of recommendations. I do believe this will improve patient safety if they're acted on. My question, though, is about accountability.
She's a humbling soul. Look at her. She wants to be and tries to be. She's sincere. She doesn't know no better. She's intelligent and all that good stuff. You have some that they can't help it. They will dedicate. They are royal and loyal to the bitter end, good, bad, or indifferent, and they still have a good heart. They just it's just because they are loyal people. I could tell she's a humbling. She can have anything she wants in the world, but she would wear and support $5 paparazzi on her neck. That's a paparazzi piece right there. That's a yep. I'm telling you. I'm telling you, that's a paparazzi. You see there? She's a humbling. She's like she supports people and stuff. Some one of her relatives or somebody. She may be working for paparazzi herself. It's just something to do to keep her busy and be in the midst of people. That looks like paparazzi $5 bling right there. She's a humbling soul. I'm not gonna say too much. She wants to help but don't know how to help. Let me see. Let me listen to see if I'm making something up just by looking at her.
Again, those statistics essentially mean that almost everybody in the country either has been personally affected or someone in their family has been affected, or they know somebody, in their church or somebody that they work with who's been affected. And I do believe that the transparency recommendations that are kind of threaded through our recommendations are very important and will get us there. But I wondered if you could reflect on that question of accountability.
One of the things, Kathy, we've done is instead of looking
Oh
for,
no, it's a Kathy. You can't trust the Kathys. They have that look, but when you turn around, oh the Catherines, not all of them, not all of them. No, you can't go by name, somebody name and judge what their character is. There's some people working for this. Do you think the people that's on this panel, all of them are fully aware, knowledgeable, and intellectual beings that are help running and governing what nanoparticles gets to your part of town? Uh, Maybe. No. What are them flowers behind him? Mr. Botanical Canna Dummy. Peter the Fern. Red Squid didn't even want to stay on Peter the Fern. He went in and ran right over it. You are not impressed. You are impressed with beings that your family ain't never even met from thousands of years ago, but you're not impressed with Pete the Fern who can take his own picture. Pete the Fern can take, wait a minute, am I talking without being heard? Pete the Fern, a plant, can take his own picture. The trees are coming back to life. They are rising, huh? Today, I want a happy Sabbath. I want to be happy. I'm going to stop the film. I got to get off the focal point and be happy because my mic is about to go out. I didn't charge it. For the plants coming to life and saying, you know what, the heat is coming from you. It's not coming from the sun. You are giving the sun the heat. You giving the sun the light. You are giving light to the sun. What? 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 Go back. Everything that I played is irrelevant in this video. You just go back to the part where I asked the question, and a lot of people probably have asked the question. How come the further you get out in space, the cooler it gets if the sun is so hot and it's burning up everything on the land, huh? Is it because the dome out there in the firmaments, the magnifiers that the prism light has to come through? Is the sun really pushing out heat? Mm-mm. Mm-mm. fire can't go no further than a certain spot part in space? Huh? If space is so hot, huh? And it smell like barbecue when you open up the air. If space is so hot, huh? If the sun is so hot, how come fire can only go to a certain point and then it has to come back down to earth? Fire can just keep going. They say that stuff be coming off of comets be fire. No, that don't be fire. It don't turn into fire and heat until it hits Earth's atmosphere, huh? The heat and the carbon and all that is coming from you are the methane. You are the fire. You is what gives light to the sun. Oh my goodness. The sun don't have no heat. The sun ain't even hot. That's how they keep messing up on they trying to get to space, y'all. Because they think they need heat, huh? Oh no, they know they don't need heat. They telling you to lie. What do you have to reconsider every shape of the earth with this information? Do you have to reconsider everything? The sun ain't even hot, huh? The sun, the temperature on it, what you looking at and talking about, they showing you pictures of volcanoes and explosions of heat and solar this and solar that. They's a doggone lie. They lying. If that's the case, there would be no satellites up there right now, okay? No, yes, that's it. I'm gone. I'm out. I'm gonna go do some artwork or something. Greater light.